All right, Kelly, we can see you. Let's see if we can hear you without.
Is that any better?
It is great.
It is?
All right,
Amazing.
yes. Well,
Great.
let's go ahead and get started then, since we are at 3:01.
That sounds great. So we just wanted to welcome everybody to our faculty panel discussion. This came about after we surveyed students and got a very good reply that students would really like to get to know their faculty. We also felt that there were a lot of very common themes that we hear in classes over and over again, and that really are great contributing factors to our development as counseling professionals. So I think everybody sits in curiosity on how these developed for our faculty panel, and we look forward to getting started. I guess I should introduce myself. My name's Kelly, and I'm the president of Chi Sig Akron chapter. Thank you.
Thanks, Kelly. So my name is Kathy Medlin, and I am co-facilitating this discussion with Kelly. I am the secretary and treasurer of the Chi Sigma Iota Alpha Upsilon chapter. Today's discussion will be a formal format. We will be asking some questions. Each of the panel members will have roughly 3 minutes to answer, try to keep us on track. The topics will include professional identity, theoretical orientation, treatment approaches, and trends in the field. If we do have time, we will get some questions from the audience. Next up, just a few things we want to have you all keep in mind. Please keep your microphone muted so we can hear the panel members give their answers. Also, we encourage you to use the chat feature to communicate any questions or comments that you might have. And then again, at the end, if we have some time, we will take those questions to the panel members. All right, real quick, I just want to bring to everyone's attention the timer right here at the bottom of the screen. So once the question is asked and the panel member starts speaking, I will go ahead and start the time. Kelly, you're up.
Okay, so we just wanted to go ahead and get to know our faculty. So we're going to take a few minutes for each of you to share a little bit about your educational history, maybe your degree programs or licensure status. Any audience, just be sure to use your chat as we're going through so we can address questions at the end. And why don't we kick off with Dr. Fye? Thanks for being here.
Thank you, everybody. Can you hear me all right?
Yes.
Right. Okay, so it's already 3 minutes. Okay, let's get started. My degree is in counselor education and supervision, and I am a licensed professional clinical counselor with supervisor endorsement in the state of Ohio. I am also licensed in the state of Colorado and Texas as well as a licensed professional counselor. I began my journey as a social work student since at the time I thought, well, it would be great to learn how to help people, which was different from other occupations in my family of origin. So I pursue social work degree, and toward the end of that degree, I thought, I really enjoy helping people, although I wish I would have more time and more in-depth relationship with people that I serve. So that's when I shifted to counseling, and my focus at the time is human sexuality. That I began to work with women who experience sexual trauma and later on transgender people and gender diverse people going through transition. So then when I knew that I wanted to be a counselor educator, to be able to educate future counselors to work with diverse population, that's when I chose counselor education and supervision as my terminal degree.
Thank you very much, Dr. Fye. And why don't we move on to Dr. Schwartz?
All right, thank you. And I'm really glad to be here. I have received all of my degrees from University of Florida. I'm from South Florida. I received a bachelor's in psychology, a master's, and a specialist degree in counseling, and then a PhD in counselor education and supervision. I was originally licensed in Florida right after I got my master's and specialist degree, and I started practicing in community mental health agencies, inpatient units, outpatient units. I became clinical supervisor of a 4-facility residential program, and then ultimately senior clinician of the 12-county mental health agency. The more I practiced, the more I realized how important it was to supervise other people. I had started supervising interns from University of Florida, and I wanted to learn more. I wanted to contribute more. That's what led me to go on for a PhD. So I received my PhD also from the University of Florida, and then started doing research, advanced practice. And the more I did that, the more I wanted to teach. And so I started teaching at the University of Florida, and then eventually became a full-time professor at Idaho State University, and then ultimately University of Akron. So I also, as Dr. Fye said, have a long history of medical professionals in my family, but they're typically doctors, nurses, dentists. And although I was pre-med originally, I realized that I really wanted to focus on mental health care, not just physical health care. And that's what led me to shift to psychology and eventually counseling. One of the driving forces in that change was my stepfather being a psychoanalyst. And so I really had a lot of guidance in the entire field of therapy, and I had a lot of supervision. Personally at home, as well as professionally. And the more I grew, the more I wanted to know, and it just led to an entire profession of supervising, practicing, researching, and advocating.
That's wonderful. Thank you so much, Dr. Schwartz. Let's go ahead and move on to Dr. Dunn.
Good afternoon, everyone. Thank you very much for allowing us this opportunity to be here to meet everyone and to share a little bit about ourselves. My name is Yue Dang, and I am an assistant professor of instruction in the School of Counseling. I have a bachelor degree in applied psychology from China, and that's where I got some exposure to counseling. Actually, I took a counseling class in group counseling, got really excited to learn about the different aspects of counseling practice in group format. And I started to research what can I do if I want to learn more about counseling. And that's when I started to realize that back then there wasn't a professional counseling program established in China. That's when I started to explore the possibility of studying in a different country. And after speaking with people who have studied in the United States in the counseling profession, I decided that that's the path I want to go. And then I moved to the United States in 2010 to pursue my master's degree in counseling. And at first, I was very, very excited to be able to work with clients, to really apply what I learned in the program to practice. And as I practiced, the more I realized that, there's a need for counseling services. There's also a need for people to train competent counselors. And that's when I started to think more about moving forward with a PhD degree to learn how to train future counselors. And I started to apply for PhD programs and got my PhD in counselor education and supervision from the University of Akron. And here I am. I think you're muted, Kelly.
Thank you for the reminder. That's an amazing story. Thank you so much for sharing, Dr. Dunn. And let's move on to Dr. Tefteller.
Hi, everyone. It's good to meet some of you for the first time, and I appreciate you inviting me to this panel discussion. I think my story is relatively unique, to be honest. I had no clue I would end up in this field when I was younger. I didn't even know I'd be in this field when I was in my bachelor's program. So I got my bachelor's degree in human communication in Arizona, where I grew up, and my original intention was probably to get either an MBA or go to law school. And after a little bit of soul searching and not really enjoying my first couple jobs, I just kind of serendipitously found the field in general, and I started doing some research. I took on a couple of bachelor's level jobs as like a house supervisor at group homes for troubled youth to kind of give myself some experience. And then I entered the master's MFT program here at Akron quite a few years back. Sometimes when the layperson or someone in my family talks about psychology in general, or still thinks I'm a psychologist, which of course technically I'm not, they're sometimes surprised when I tell them that I honestly don't know much about psychology beyond the typical norms that you would going to grad school. I took one psych class in my entire life, and that was a Psych 101 class when I was a junior college football player many, many years ago. So I sort of stumbled upon the field, and I'm eternally grateful that I did. I am a independent marriage and family therapist with my supervisory designation, as well as a professional clinical counselor. And I also have my American Association for Marriage and Family Therapy approved supervisor status, so I can do things nationally from a supervisory level. I graduated from the program here at Akron when I was still dually licensed for the MFTs, so that's why I got both licenses, and I'm glad I did. I really enjoyed working with both individuals as well as couples and families. What else do I need to say? Oh, my PhD, of course, is also in counselor education and supervision with a marriage and family therapy focus. I honestly, again, did not know I wanted to be in the field, and once I found it, I was glad. But even as a PhD student, I wasn't sure I was going to teach. I enjoyed some of my TA positions, but I really just plan on being a full-time clinical counselor at some point. I come from a family of a lot of medical professionals and people who value education as well. My dad was one of those guys who always said, if you're going to get a degree, get the terminal degree. So even not intending originally on teaching, that was my plan. But I was able to secure a visiting position many years ago, which eventually turned into a permanent position. And I'm extremely grateful that I did, because I really enjoy teaching. I really enjoy supervising, and I enjoy my own clinical work part-time. I feel that I'm a better clinician because of my teaching, and I feel I'm a better teacher because of my clinical work. So that's sort of me in a nutshell, and I'll leave it at that for now.
Thank you very much.
All right, now we're going to move on to professional identity. So we're going to go ahead down the list again and start with Dr. Fye. Dr. Fye, can you tell us a little bit about your professional identity? Like, when did it begin to develop? How has your career evolved, or how is it evolving? And what kinds of career experiences have you had, and what led you to pursue these areas?
Yeah, there's an echo here. I switched to my cell phone. So I think I was fortunate that I got a chance to work with different professionals within the hospital setting. And in that setting, I realized that we're pretty much doing the same thing, but different roles. So we focus on patient or client care, but there are different functions that each profession kind of take. So I started to realize early on what's similar, and what are similarities and what are differences. And so with that, it helps me focus on my job, right? What I do. And from what I do, to understand what I do, to what's my identity was in that work setting. And that translates to when I work with patients, I refer to patients as, because I was in a hospital setting, and also in the community work, I began to realize also that different counselors also have different job function. So then it really kind of fit into the whole understanding of who am I, right? What am I contributing to the profession in a whole? And at the time, I started my work with transgender and gender diverse people, starting with pediatric patients to adult patients and also their family and loved ones. So it really helped me again, focus on my identity as a counselor who focus on diverse population and social justice. That kind of led me to feel strongly that, what, I wanted to be able to train people to do the same job that I do. And I started my career, I would say many moons ago. So you don't figure out my age. Although when I say many moons ago, you just realize, oh, she's from, the 70s. So, but with that though, like it really helps me kind of start with the span of my identity as a counselor to my aspiration to who I am now.
Kath, I think you were muted.
Well, just thinking of the pattern, is it my turn? Okay, I'll just go ahead just to keep the ball rolling here.
I'm sorry, I
Thanks.
didn't know I was muted.
Okay. Should I
Go ahead, Dr. Schwartz. Yes,
take
it's
the
your
mic?
turn.
Okay.
Same question. Thank you.
All right, thank you. I was very fortunate in my career because I've had a lot of opportunities to learn about the whole continuum of mental health care, different lenses that people use, different professional identities. Having worked in an outpatient setting, residential, inpatient psychiatric hospital setting, I had a really stark picture of how different professionals view clients and recovery so differently. Originally, before moving into a counselor education supervision PhD program, I actually started in a counseling psychology PhD program. And that right there it taught me a very different way of thinking about people and how to advance the community through client care. It was much more of a scientific left brain kind of a focus. It was very experimental, very research oriented, and I realized very quickly I wanted to work more with human beings who are suffering rather than work on people, thinking of them objectively, quote unquote. So that's when I transferred to counselor education and supervision, because I realized that in counseling, we have much more of a holistic, humanistic kinds of philosophy about how we work with other human beings. I also realized through working with psychiatrists, psychiatric nurses, clinical social workers, et cetera, that the medical model perspective of understanding and serving clients was really not very well aligned with who I was as a person. Because the focus seemed to be much more on coming in from the outside and eliminating symptoms, quote unquote, of mental illness to help people just stabilize, come back to homeostasis. And then after that, the client was pretty much sent on their way. So it was a very allopathic, external, almost forced kind of treatment approach. And the more I learned about that, the more I realized how important it is to think of people from a wellness model, helping people grow as human beings developmentally, and not only to recover from mental illness, but also to continue developing throughout their life and preventively in the future, so they could take more authorship of their own life and not need therapists or the mental health system at all potentially in the future. So I really over time developed a much more holistic wellness developmental approach to understanding and working with human beings who are suffering, very different lens, with the ultimate goal of helping our clients become their own therapist so I could put myself out of business. That's really what the end result was of many years of a windy road finding my path.
Great. Thank you so much, Dr. Schwartz. And Dr. Dunn, you're next up.
Thank you, Kathy. And
welcome.
my first exposure to my professional identity development was me choosing to get into an applied psychology program to start with. And my mother, who had a background in educational psychology, it was the person who taught me into applied psychology to start with. And as I was in my undergraduate degree program, I found my interest in counseling. I would say that my real professional identity started to develop when I was in my master's program. I actually was really excited to get into a master's program in counseling and became a member of the American Counseling Association in my very first semester in my program. But I have to say that my professional identity is further solidified when I was in my doctoral program, of course, because of all the great people that I worked with in my doctoral program. I started to learn more about different professional organizations, get more exposure to those organizations, got the opportunities to present at multiple conferences where I also get to connect with the other counselors, counselor educators. And I believe that further demonstrated my identity because of my professional involvement in all those different professional organizations, such as American Counseling Association, Association for Counselor Education and Supervision, Ohio Counseling Association, Pi Sigma Iota, of course. And whenever I go to professional conferences and get to interact with those people, it's always a great feeling to learn and connect. It tells me that I'm in the right place.
Great. Thank you for sharing that. Okay, Dr. Tefteller, we'll have you round out this question for us.
Sure. I definitely, a lot of what my colleagues have said before me definitely resonates in terms of how I sort of came to the conclusion that whatever I did, I wanted to be in something that was more of a holistic and wellness-based approach, less scientific, less research-based. I definitely respect and understand the role of all those different aspects of what our colleagues do, but I wanted to do something that had more to do with direct interaction with folks and with families and helping them to alleviate that suffering that Dr. Schwartz is talking about earlier. I also resonate with what Dr. Schwartz said about trying to put himself out of business. That's a common thing I'm telling my students, is that our job as future MFTs or clinicians in general, if we're doing a good job, is to get ourselves fired sooner rather than later. So my identity really obviously didn't form. I mentioned earlier how I kind of sort of stumbled upon this career later in my mid to late 20s. But when I started working in those group homes, I definitely noticed that my own way of thinking and looking at healing definitely centered around a systemic lens. I worked at 2 different group homes, and they were both very good and good places to work. They were both very effective and did great work with the teens that they were serving. But one was a little bit more committed to involving the extended family members and caregivers and parents of the teens that were there, and I definitely saw a little different, a different sense of change and of growth and of what I presumed would be more long-term health for these individual teens, as well as the environments that they were going back to, and hopefully produce less recidivism. And so when I went to our program, I ultimately chose MFT because it just kind of made sense to me, and I got duly licensed. But even today in my own clinical work, when I work with individuals, I know that nobody exists in a vacuum. And inevitably, most of at least individual clients that I work with, we're talking about their individual symptomology, but it's almost always related in part or largely to current or past relationships. And so I tend to view everything through a systemic lens, and that's where my core identity lies, really, is doing systemic work and thinking systemically and holistically, no matter what the modality is that I'm working on. So that's sort of where I come from, and how I arrived at that point is just through personal and professional and academic experiences that kind of led me to thinking a little bit more systemically in how I work. So.
All right. Thank you so much. We will move on to our second question. Kelly?
Okay, so another hot topic in the classroom that students hear a lot about, and we'd love to gain your insight and experience around theoretical orientation. What theoretical foundation or foundations resonate with you or have resonated with you the most? And how have these foundations guided your work and your careers? And I will mute, and Dr. Phi, we will get started with you. Thank you.
This is a difficult question, actually, and I'm gonna need more than 3 minutes. I'm already wasting my time 2 seconds. So I would say pretty much all the theoretical foundations I have learned actually, I don't know if it resonates, but it's contribute to my understanding of human suffering, except Glasser, right? So that's my thing. Like I feel like I could pick a little bit from each theories or treatment approach that I learned and actually apply to my understanding of how pathology, right, or suffering, reason of suffering is kind of developed in people. I would have to disclose though, when I was going through my advanced training, at the time, solution focused brief therapy was the thing. And I was heavily taught through that model because the school that I went through also has a very strong MFT program. So structural family therapy and strategic family therapy and solution focused brief therapy, those are 3 models that we generally was trained on. And I actually found that those 3 models are very helpful. I was more interested in solution-focused brief therapy at the time because I thought, well, it's evidence-based, is brief, and also it seemed to be effective, right? But later on, I started working with children by accident. It just because, a lot of client and caseload was children. And a lot of my faculty and mentors at that time were trained in play therapy. So I began working toward play therapy certification and see a lot of pediatric patients. In that, though, with the experience working with transgender people, I was then, discover EMDR therapy. I was introduced to EMDR therapy, and I thought, wow, eye movement desensitization and reprocessing therapy is really resonates with me most in terms of how I conceptualize a person's suffering, a pathogenesis of how these sufferings being developed and carry on throughout the person and the person in relation to other people, and also the functioning of each individual related to traumatic experiences that they would have regardless of the disorders that they presented in therapy. So, and then I went on the path of getting a training and certification in EMDR. I still have 6 seconds left. Thank you.
Thank you. All right, Dr. Schwartz.
Yeah, when I started this profession, I went in with a very open mind. I knew that I was leaning towards a humanistic kind of school of theoretical orientation. And I really delved into a lot of specific approaches. For example, I actually knew William Glasser very well, and choice theory, reality theory, or therapy, I think has a lot of benefits. I had personally corresponded with Aaron Beck, cognitive therapy, through some of the research I did. He developed an instrument based on some schizophrenia research that I published. I had met Albert Ellis, REBT, and I did realize that all of these different approaches and the more than 600 different types of counseling or therapy all have different benefits, but they all had major limitations because all of them came from one specific angle, only touching on one small component of the human experience. And through all of those relationships, all of my reading, research, and practice experience, I settled on mindfulness-based approaches as my primary theoretical orientation. And the reason is because everyone has a mind and everyone can learn to accept, sit with, and learn from their own personal experiences, their brain and their body. It's a very, very holistic approach. It's a homeopathic approach. Most of the other approaches to counseling or therapy are more allopathic. For example, cognitive therapy. If you have irrational or dysfunctional thoughts, etc., what are the interventions? Coming in, counteracting those, imposing the opposite so someone doesn't think or conceptualize their world that way. Mindfulness isn't like that. It's actually accepting who, where, what you are, learning from it, accepting that in the present moment, and then learning conscious understanding minute by minute. So wherever you are in life, you could use that information to improve, to become successful, and to literally be part of your own wellness evolution. So mindfulness, I think, has benefits for everybody at every stage of counseling, not just the action stage, which most other approaches focus on. And for me personally, it really fit as a human being. So I ended up specializing in that approach.
Great. Thank you for sharing. Dr. Dunn.
Thank you, Kathy. I agree with what Dr. Fai said earlier, that all of the theories in a way contributed to my understanding of my work with clients in practice. I was trained heavily on CBT, and also I learned a lot about DBT in practice when I was in my master's program. But later on, as I reflected on it, I realized that the theories that resonate with me most are humanistic and existential theories. And in fact, two of my prior supervisors who helped shape my theoretical orientation are sitting on this call with me together here. So I really appreciate having that opportunity to dig deeper into what I believe and who I am as a person and as a professional through my practice with clients. Because by reflecting on those theories, humanistic and experiential theories, I started to better understand clients' suffering, their experiences, and also they kept reminding me that as practitioners, we don't know everything that our clients are going through. They are the experts of themselves. And we always have to be humble and to learn from their perspectives as far as how we can best support them through this process. So that's my take on theoretical orientations.
Thank you, Dr. Dunn. And Dr. Tefteller.
Well, how do I say this? I echo a lot of what my colleagues have already said, and especially going back to Dr. Fai's comment on learning something from all the things that I've learned, all the theories I've learned. I'm a pretty integrativist therapist at this point, I would have to say, and I tend to borrow from those things that I think will be most helpful on a case-by-case basis, since each client is different. I also have a kind of a strange dichotomy in my mind in terms of how I think about theory, which is kind of ironic because I teach most of the theory classes, at least in our MFT program. I'm a big believer in theory as a foundation, but something that oftentimes will tell students as they get near to their clinical work, and especially if and when I'm teaching practicum, is I'll tell them that all the theory things that I've drilled into their heads for the last few semesters, I want them to just kind of temporarily forget for the most part. Because I've seen firsthand how supervisees and brand new clinicians can go into a therapy room and there's so many different things going on in their mind, kind of going back to Dr. Schwartz and mindfulness, they are not present at all. They're not just sitting there being a genuine person with their clients and making them feel comfortable in that space because they're so wrapped up in their head about what's the next question, what's the next thing I do, am I doing it right? what theory is this intervention tied to? And I believe those kinds of thoughts are important long term, but as you're growing and developing as a clinician, you kind of have to get outside of that stuff and think more about the standard micro skills that are somewhat anti or universally theoretical. But to answer the actual question, I tend to gravitate towards some of those more traditional ones in the MFT field, like Dr. Fye mentioned, mainly being things like structural and Bowenian, and even a little bit of emotion focus if I'm working with couples. Another thing I'm oftentimes telling my students is that you can be, or you can believe in like the old school modernist approaches, but do it from a more postmodern, client-centered kind of approach. In my experience clinically, we oftentimes talk about how we should be client-centered and take a one-down position with our clients, and I definitely believe in that. But I also see a lot of clients, they want to have some kind of instilled hope that things will get better, and they're coming to you as a professional because you have some expertise in some kind of area. And so I believe in building strong rapport. I don't believe in pulling punches. Once rapport is built, I'm very direct with clients. I teach my supervisees to be the same way. And I think it's interesting because I know that clients want to feel heard, and they are the experts on their lives, but at the same time, they want us to know something too. I know, at least for me personally, if I were to go to therapy, and certainly when I go to a medical professional, I don't want them to tell me that I know as much about my body as they do, because I'm living in my body, but they're the experts on what's going on. So I find for myself sort of a mixture of using modernist approaches, but doing it from a very egalitarian and collaborative approach that's more postmodern seems to work best for me in my clinical work, if that makes sense.
Yeah, definitely. Yeah, definitely see a lot of commonalities here. Whoops, there's the timer. Yeah, great to hear from everyone. Certainly some differences in there as well. Okay, next we will talk to you guys about some treatment approaches. Can you give us some idea of what you found to be most useful or effective and why? Dr. Fye.
Yeah, so I think the question is on treatment approaches that we believe it's helpful, right?
Yes.
And obviously, I believe that EMDR is the most efficacious and effective method in helping people. Originally, this model was created for combat veterans, or people who experience PTSD in a larger scale. But as we grow as a profession and in the field, we know that big scale trauma or single incident trauma can be difficult to deal with, but also chronic trauma that the person continues to expose, like adverse childhood experiences, can be also difficult to treat and contribute to a lot of symptoms that are being presented today. So that's kind of drove me originally to focus on something that was more tangible. I would have to say that when I first trained in either in individual or family therapy, the model was more like humanistic, like human validation model. Very humanistic and focused on the process. But the result is kind of unknown. I was trained extensively in child-centered play therapy. And if you know about this kind of therapies, that they're kind of non-directional therapy where the results are actually not seen per se, but you experience that. But as a counselor, I believe that it was, we take into accountability piece as well. How can we actually measure, evaluate, and see that the treatment that we're providing is actually effective? It's actually create some change in clients, right? It's measurable. So that's when I found EMDR, and that I felt like it was kind of the most effective tools to actually help people to understand stuff. So like I'm going to show you, this is the pulsator, right, that we use is based on bilateral stimulation that taking into account from what cognitive standpoint, mindfulness standpoint, the mind body stimulation, but also bilateral that start with eye movement, but actually it can come from many different things. It could be movement, it could be anything else. So, and with that, I believe that those things, especially when you work with children, the more effective because you can see the result right away.
Okay, I think Kathy, you're muted again, so I'll just go ahead and get started.
I don't know
Um,
how I keep getting muted.
um, for my treatment approach, I would go back to mindfulness-based interventions, but it's more than that. When you think about mindfulness, we're talking about being centered in the present moment and non-judgmentally. So it's about paying attention. It's also about accepting who, what, and where you are, and using all the information available from your brain and your body to inform you about how to live more skillfully. And there are different kinds of mindfulness-based approaches. There's mindfulness-based stress reduction, mindfulness-based cognitive therapy, acceptance and commitment therapy, which is a wonderful cognitive/mindfulness-based approach, and others. DBT, dialectical behavior therapy, is in the mindfulness school. So there are a lot of different approaches to learning mindfulness and recovering from different forms of human suffering using those interventions. But for me, the core of it all comes down to the relationship, the therapeutic alliance, which is in part a healing approach in and of itself. One of the seminal books that I've read is called The Heart and Soul of Change. And it really reviews about 30, 40 years of research on what helps lead clients to change for the better, more longer term. And about 30% of all change efforts really come down to a positive therapeutic relationship with the clinician. So to me, that's at the core. And then mindfulness-based approaches can build upon that, including cognitive or behavioral or other kinds of interventions, but from a mindfulness framework. So someone could take that with them and use that approach outside of the therapy room with the professional and learn how to gain more fullness of their mind every single moment of the day, and ultimately have more authorship over their own life.
Thank you, Dr. Schwartz. Guess we all would have guessed that you were going to go with the mindfulness-based approach on that answer. Okay, Dr. Dunn.
Thank you, Kathy. And I echo a lot with things that have been discussed. And I think part of this question was also discussed in the prior question when we all shared our theoretical orientation. And for me, I agree with what Dr. Teller just mentioned, that, the importance of therapeutic relationship. And I value that a lot. And when it comes to implementing their treatment approaches, I pay attention to the relationship that I can build with clients, along with the holistic perspective that Dr. Schwartz mentioned. And I also have training in wellness counseling. I try to incorporate that into my practice to bring a more wellness-based, developmentally appropriate, and holistic perspective to understand the client's experience. And even today, I still remember this vividly from my supervisor saying that, your goal as a counselor is to help your clients to become their own counselors, right? But that's not just that. That's not just it. We want to really be present with them. And a lot of times, I know that I talk about this in classes as well. Is that I'm not making this up. Counselors have found that as you work with clients will will remember whether or not you were there with them, you were present with them, versus the techniques or the interventions that you actually used. Not just, I'm not saying that interventions are not important, they are, but we have to really pay attention to how we present ourselves in the session and how we approach our clients and how we engage them in the sessions, if that makes sense.
Yes, it does. Definitely. Okay, Dr. Tufteller, do you have anything to add?
Not much, a little. I mean, I think I actually stole some of my own thunder. I answered both questions previously in discussing some of my theoretical orientations and my approaches as well. But I will just reiterate what has already been said a couple times about the importance of the therapeutic relationship and that therapeutic bond and the research that's behind discussing the importance of not only the theories and the interventions, but that actual genuine connection you make. Another thing that I oftentimes will say in my theories classes I teach, I'll tell my students, what really matters is that connection. And hypothetically, if of all these masters of these theories that wrote these textbooks that we're reading and discussing right now were to work with client A, and there just wasn't that connection, and you were to work with that same client as a brand new intern who kind of knows nothing, but for whatever reason there's a good connection there, odds are there would be more positive outcomes working with you in spite of what you don't know compared to the other person. So I really, really emphasize that to my students. And as a as a systemic therapist, I'm also emphasizing quite often with my students the importance of, at least in relational context and relational therapy, the importance of process over content. I've said to my students many times, I've said to my couples and families many times, if you guys want to pay me to come here every week and basically just mediate arguments or give you my thoughts and advice on the flavor of the week in terms of your problems and your arguments and what they're about, I can do that. But more importantly, I'm here to teach you how to fish as opposed to just giving you fish each week. And so I really believe as a systemic therapist, the value of teaching folks, and I tell them our MFT students, you're going to be eventual relationship experts and communication experts more than anything. And so teaching folks how to engage in a more healthy process of relating to one another, of empathizing, of communicating and understanding where each other is coming from is probably the most valuable tool we can give our clients, at least in a relational context. Another dumb analogy oftentimes used is if you're really good at mathematics, which I'm not, it doesn't really matter what the numbers are in any given equation. It's understanding how to do the equation. It's understanding the principles behind the equation. And to me, that's what human relationships and human communication is about, is understanding the way to do it, that process over just what the specific problems are. So that more often than not is my personal approach that seems to work best with my relational clients. And when I say some of these things to them, you can sometimes see the light bulb go off in their head that it really is more about how they're interacting and not so much what they're interacting about. So that's where I come from typically in my clinical work.
All right, thank you. All right, last topic, trends in the fields. So basically here we'd like to hear about any trends that you're seeing related to this field, individual or family counseling, and where do you go to keep up to date on these types of trends? Dr. Phi.
Yes. More and more, I think it used to be that we think that we work to provide counseling or psychotherapy in isolation, right? So clients may present with, let's say, symptoms of depression, then we kind of work on to address that, either from the wellness perspective or from pathological perspective. And then we don't really take anything besides or beyond the counseling room into account. But more and more, we know that we don't work in isolation. A lot of time, clients who suffer from symptoms of mental illness, they also suffer in other areas in life, either physical, occupational, medical. And you see now that more and more effort is being placed in interdisciplinary work that in agencies, community agencies, the hospital focus on integrated care that would require you as a counselor or as a family therapist to work collaboratively or in conjunction with other professionals, whether they're medical or in school or in the community, in order to help the client to reach that functional health concept that is not just that they're healthy, but is functional health is a concept where you really focus on the health that translates into all aspects in life, not just physical or mental health. So I think more and more, I've seen that, of course, trauma-informed care, that's also the trend that has been going in a profession, especially with COVID and after COVID. You see that it's not just the pandemic that we experienced, but also trauma that people sustained from that experience. And so trauma-informed care, though this concept was introduced 10 years ago, I think it's going stronger and stronger, and actually in every field, not in the counseling field. So I think those are the two trends that I have seen in the field.
Okay. And Dr. Schwartz.
Yes, the two trends that Dr. Phi just talked about, I think are absolutely right on. The interprofessional nature of how all counselors, MFTs, other types of mental health professionals have to work within is absolutely becoming like imperative. Doesn't matter if you work in a mental health agency or a school or even a private practice, EAP, most likely you and or your clients are going to also be working with psychiatrists or psychiatric nurses or social workers, et cetera, et cetera. And so it's really important for people in our professions to not only know their own identity, but know how to effectively communicate with people from other professions with different identities. Secondarily, trauma, as Dr. Phi mentioned, is by far one of the strongest trends right now in our society. It's become a household word, and there are many specific interventions focused on that. The two that I would add in addition to those two, which have been around for a while, are multicultural / diversity, equity, and inclusion types of counseling. The world is becoming much more global in nature. Counselors are not only working with different people of different races or gender identities or socioeconomic statuses, et cetera, but also people of different nationalities. And so it really takes a very open mind and a lot of multicultural competencies to work with such a diverse array of clientele. And finally, somewhat related to that, is social justice. Again, it's been a trend for quite a while, but more so given all of the social inequities and violence and other trends sociologically, counselors, MFTs, other mental health professionals can be a key part of society as advocates, not just for clients, but for systemic change, community-wide change, and helping our clients learn to be advocates for themselves. So we need all of these skills, not just in how to communicate with other professionals, how to negotiate trauma, but also how to deal with diverse clients and helping them learn how to be advocates so we could be advocates for our profession.
Thank you, Dr. Schwartz. Dr. Dunn, do you have anything to add to that?
Certainly. I definitely agree with the trends that Dr. Phi mentioned. Trauma-informed care is such a big thing in general, and also specific treatment like EMDR. And as Dr. Schwartz mentioned, DEI-related effort in our profession. And another thing that I want to add onto the list is technology. Whether we like it or not, we see it's being widely used. And as many of you sitting here on this call have had firsthand experience serving clients through using technology, you know that it's not as simple as you open the app and log in, that's it. It's not like that. There are a lot of ethical considerations, practical considerations that go in it. And by technology, I'm not just talking about telehealth. I'm also talking about technology assisted practices such as assessment, right? Those kind of things are things that we see coming stronger nowadays, and it's really important that we pay attention to relevant laws, rules, best practices, and always learn to make sure that we're up to date about what's coming up in the profession and how we can competently, professionally, and ethically utilize all those different technologies to serve our clients.
Great, good addition. Dr. Tufteller, did they leave anything for you?
Not much. I might have one small additional thing. I just will also echo everything that's already been said. And then following up with the technology part, I was going to mention specifically teletherapy and telesupervision, especially is becoming more and more prominent, particularly in the MFT field. I mean, I remember it wasn't that too many years ago. I'm usually the one who teaches the ethics class in the MFT program. And it wasn't too many years back when you start to cover technology and telehealth, it was still sort of that fringe thing that was maybe part of the future. And some folks do it, but it's not super common. And of course, the pandemic kind of forces all to get used to this stuff really, really quickly. And it's fairly commonplace now. And with the prevalence of more and more, modems or modalities and servers that make it possible that are HIPAA compliant and whatnot, I definitely see more and more of an upward trend in folks using telehealth for services as well as seeking out supervision. I was also going to add, it's not super new, but there seems to be more and more emphasis, especially in light of or aftermath of the pandemic as well, the need for with the therapist work and self-care for clinicians because of that secondary trauma that was referenced earlier. It's so important to be able to treat our clients for the various kinds of trauma they've experienced, including the pandemic and everything that it caused, but also for clinicians themselves. It's difficult sometimes. I've seen a little bit of an uptick with my students and my interns in terms of their ability to just engage in time management and sufficient self-care so they don't get at least even mildly burned out. And so I think that's something that's at least I'm circling back in terms of being an emphasis in the overall general field is the need for clinicians taking care of themselves so they can adequately take care of their clients. So I'll add that.
Thank you so much. Yeah, we appreciate that. So much good insight, I think. Again, relating this to what our students are hearing in the classroom and all of your personal experiences and insights. I particularly did enjoy the insight around trends in the field. Looking at the time, it looks like we just have a couple minutes left. I think we have a couple in the audience. Are there any questions that we'd like to pose to the panel?
Kathy, maybe if you don't mind, could you just reframe what Kelly said? It was difficult to hear.
Yeah, sure. Again, thank you to our panel members for the information you've provided to us today. We're just going to check with the audience to see if there are any questions that came out of this discussion that anyone would like to ask. Go ahead and put it in the chat box. Not seeing anything. Or if there's anyone that's on the call that would like to unmute themselves, ask a question. If maybe they don't have the option to chat.
We just answered the questions that well, I guess.
Okay, we do have a question. How much psychoeducation and TLC do you implement in your counseling? Any of the panel members can take this one.
I would say a decent amount. I mean, I find oftentimes that a lot of the consternation that clients originally present with can be at least a great bit solved by just some simple psychoeducation or normalizing. I had just had this family come in the other day with a young adult son who's living at home while going to college, and by all accounts, this is a great kid, and we're just talking about some little minor squabbles about what to do and details and logistics about what expectations are, and they thought it was the end of the world, sort of. And so us having a simple discussion, but also me normalizing quite a bit, that the differences or the uncertainties they had with having an adult child living at home. That's just an example. It just helped. I could just see the kind of the weight get lifted off of their shoulders. So I think psychoeducation goes a long way in helping folks understand that a lot of these things are something that can be dealt with and that are pretty common, and there's answers out there for them that gives them hope. So I think it's very important.
Yeah, I agree. I think a lot of times, we don't really typically call it education, right? But although we know it's education, but we generally refer to it as a skill building, coping strategies, right? To really help people to translate what they learn in therapy or in counseling to everyday life, because we only with them 45-50 minutes a week typically, but we rely heavily on them to actually execute a lot of skills that they learned here outside of the counseling room, so that we see some improvement in different areas of their life. Yeah, skill building is a big part.
I would just like to add, though, and this is just coming from my own perspective, based on theoretical orientation and other topics we've already talked about, that psychoeducation types of interventions can potentially be helpful for certain concerns if they are concrete, and there is also concrete information to share. But I do think that therapists need to be very cautious about using too much psychoeducation, because it can tend to be imposed upon clients, and it could even move into the realm of being preachy in some ways, but it doesn't necessarily facilitate the process that Dr. Tafteller talked about, which is correct. We're trying to facilitate a process of self-understanding and growth within the client, rather than just presenting them with information. So we have to just be very judicious about how and when we use psychoeducation.
Thank you. All right, well, we are 3 minutes over, so in the interest of time, we will wrap up. I'd like to thank the panel members for joining us today and sharing with us all of the information and their wisdom and their knowledge. It is much appreciated, and this has been recorded, so we will provide this link out to others. Perhaps this just wasn't a good time of day for others, but they will have the link available to catch this when it is convenient for them. So again, thank you so much. On behalf of Chi Sigma Iota, we really appreciate your time and hope you have a great rest of your day.
Take care. Thanks for having us.
Thank you.
Thank you, everybody.